Ladies and gentlemen, thank you for standing by. Welcome to the Identifying and Meeting the Language Preferences of Health Plan Members webinar. At this time, all participants are in a listen-only mode. If you should require assistance on today's call, please select star then 0. I would now like to turn the conference over to our host, Ms. Alana Noor. Please go ahead.
Thank you. My name is Alana Noor. I'm with the Lewin Group. Welcome to the webinar, Identifying and Meeting the Language Preferences of Health Plan Members. Today's session will include a 60-minute presenter-led discussion, followed up with 30 minutes for a discussion among the presenters and participants. This session will be recorded. A video replay and a copy of today's slides will be available at resourcesforintegratedcare.com. The audio portion of the presentation will automatically stream through your computer. Phone lines for this presentation are also available. To access the number, click the black phone widget at the bottom of your screen. The Centers for Medicare and Medicaid Services is accredited by the International Association for Continuing Education and Training to issue CEUs. We strongly encourage you to check with your specific regulatory boards or other agencies to confirm that courses taken from these accrediting bodies will be accepted by that entity. CMS offers CEUs for individuals looking to obtain credit for attending this webinar. In order to obtain these credits, you must complete the post-test through CMS's Learning Management System. Additional guidance about obtaining credits and accessing the links to the post-test can be found within the Continuing Education Credit Guide in the resource list on the left-hand side of your screen, or at the Resources for Integrated Care website. This webinar is supported through the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. At this time, I'd like to introduce our speakers for today's webinar. Darcy Graves serves as Special Assistant to the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. In this role, she assists in the coordination and implementation of priority office-wide programs, policies, and products. In addition, she provides subject matter expertise in areas such as culturally and linguistically appropriate services, cancer, health disparities, and health equity. Ms. Graves holds graduate degrees in communications, religion and sociology, and public policy, and has nearly 20 years of professional and academic experience in the fields of cultural and linguistic competence and health education. Her commitment to sharing her insights from her experiences and a profound sense of community guides her work to enhance the quality of people's lives. Albert Cardenas has served as the Director of the Customer Service Call Center, Cultural and Linguistics, and Enrollment and Reconciliation Departments at CalOptima since 2015. He previously served as the Manager for the Customer Service Call Center. Mr. Cardenas has over 20 years of experience in healthcare and has extensive experience interacting with health plan members. Due to his experience in the Customer Service Call Center, he knows the on-the-ground experience that members have with health plan staff. He has built on these experiences through his work as the director and aims to bring a strong commitment to cultural and linguistic competency into his department. Marta Pereira has been the Executive Director of CLESE, the Coalition of Limited English-Speaking Elderly, for the past 10 years, with 4 years of previous experience on their board of directors. Marta has 25 years of experience in mental health and nonprofit management. Prior to joining CLESE, she held the position of Director of Clinical Services at the Polish American Association, where she implemented a variety of programs addressing the needs of minority older adults and conducted cultural competency training. Martha shares her experience and knowledge on issues of aging and policy through speaking at conferences and developing cultural competency trainings. As Executive Director of CLESE, she manages the network of HCBS minority providers, and she was instrumental in creating CLESE's Care Coordination Language Access Assistance Services for health plans in Illinois. After the presentations from each of the speakers today, you will be able to recognize the need for identifying and meeting language needs of members with limited English proficiency, identify a variety of methods for collecting member language preferences, such as using data provided by the state or health plan generated data, recognize approaches to meeting language needs, including translation and interpretation services, and identify strategies for hiring and training health plan staff to provide linguistically and culturally competent services. Today's webinar will begin with polls, and then we'll move into a presentation from Darcy Graves on effective communication with individuals with limited English proficiency. After Darcy, Albert Cardenas will share strategies from CalOptima on identifying member language preferences. Martha Pereira will share her experience partnering with plans to meet member language preferences. And lastly, we'll have plenty of time for a question-and-answer period with our speakers. To begin with, we'd like to start with a first poll. For this poll, we'd like to find out from our audience which of the following best describes your professional area. If you could select your answer, and we'll review the answers together in a moment. Wonderful. Thank you, everyone, joining us today. It looks like the majority of attendees are from health plans, and particularly case managers, care coordinators, administration, and management. Thank you so much. Our second poll, we'd like to know, in what setting do you work? If you could select your answer here, we'll review the answers in a moment. Great. Thank you so much. And in alignment with our previous poll, it looks like the majority of you are from health plans, but we also have some attendees from community-based organizations as well. Thank you, everyone, for sharing. We will now move into the presentation part of the webinar. I will pass the presentation off to Darcy Graves to get us started.
Thank you so much, Alana. And good morning and good afternoon, everyone. It's great to be here today to talk to you about effective communication and the importance of effective communication in working with not only individuals with limited English proficiency, but all of their patients and beneficiaries. And in that vein, on the next slide, you will see one of my favorite quotes when it comes to talking about communications. And it's a quote attributed to George Bernard Shaw, and it's the single biggest problem in communication is the illusion that it has taken place. And I think this is a quote that we can all relate to because we've probably all seen conversations happening between, either our parents or our children or our neighbors where people think they are communicating, but in reality, it is just an illusion. And this illusion is deeply problematic when we look at it within the healthcare setting. And one of the things that we know is that poor communication can end up being one of the primary reasons for litigation, for poor health outcomes, and many other things, which I'll highlight during my brief overview today. If we go on to the next slide, I want to talk a little bit about healthcare quality. And these 6 domains of healthcare quality were identified by the Institute of Medicine back in 2001. And we talk about quality in terms of safety, effectiveness, patient-centeredness, timeliness, efficiency, and equality. And I think it is safe to argue that if you don't have effective communication, if you're not truly communicating with someone, with your patient or with your provider, then it's easy to say that your care is not safe. It is not necessarily going to be effective. It certainly isn't patient-centered or efficient or equitable if you're not successfully understanding your diagnosis or giving permission to do whatever, to treatment, to surgery, and any of those things. And communication, when we look at it in the healthcare setting, becomes it's exponential. I think we lose track sometimes of how much communication takes place during the healthcare encounter, both behind the scenes and just in all of the moving parts. And if we go on to the next slide and into this video, it shows the number of communications between providers and patients. And hopefully the video will start playing in just a moment. But here we go. So this is an illustration on the complexity of patient care that came from Dr. Matthew Press, who described the interactions he had on behalf of a single patient who he had referred to for a tumor resection. And this diagram shows all of the different kinds of communication that took place over the course of 80 days. There were over 40 communications, 5 procedures, and 11 office visits. And you can imagine that during the course of all of these things, the patient was receiving written communications, they were receiving phone calls for scheduling, they were receiving emails about where to go and what to do, and then there was also the office visits themselves. So now, so that's just, that just shows the plethora of communication. And then that's just in the clinical setting. When we go to the next slide, we think about more aspects of the patient experience. And while many of these points may be outside of your purview or your organization's purview, they all still culminate in the patient experience. And you can look at the three green boxes as being the boxes that were kind of that were addressed in the video we just saw, the meeting with the nurse or the physician's assistant, meeting with your clinician, going through therapy or surgery or treatment. But then you see all of these other parts of the patient experience in blue, and you see that there's a lot of other points of contact where communication and being able to understand what's going on is important to the patient. Making sure they have insurance coverage, finding a doctor that is included in that coverage, getting an appointment to see the doctor, arriving at the office or hospital or clinic, wherever that is. So did they have to take public transportation and understand that, or were they able to get the GPS on their phone to navigate to where you're located? And then is it easy to determine where to park? I know, I'm a native English speaker, and there are some times where I arrive at a new healthcare facility, and I struggle with where am I allowed to park, how much is it going to cost, what are the chances I'm going to get a ticket, and trying to figure out all of those things. And then finding the front door, finding your doctor, checking in, filling out any additional paperwork that you might have. Then seeing your clinicians, checking out next steps, going to the pharmacy. I saw we had a couple of pharmacy folks on this webinar, and I'm always excited to see that point in the healthcare continuum included in these webinars. Thinking about the tests, the blood work, the radiology, any of those things, those prescriptions and orders that the clinicians might have written, and then getting home. All of those pieces all kind of contribute to the patient experience and all involve a great deal of communication on behalf of the patient, the family, and those that are serving them. So now we've talked a little bit about all the different places that communication takes place. Why is it important? When we look at the next slide, we see that patients who report effective communication are more likely to be satisfied with their care. They're more likely to share pertinent information for accurate diagnosis of their problems. They're probably, if you're not feeling like you're being listened to, or if the communication doesn't feel effective, you're less likely to share information that may be relevant to your diagnosis and to coming up with your treatment plan. They're more likely to follow advice, and then they're more likely to adhere to the treatment that was prescribed to them. On the flip side, we look at the next slide, and we see what ineffective communication is attributed to. And now we're going to the next slide on ineffective communication, slide 18. And so we see, ineffective communication results in patient-provider miscommunication, which may result in delayed diagnoses, misunderstanding of care plans, medication errors, lack of follow-through by the patient, and a misuse of health services. There's also that lack of trust and confidence in the provider that we just alluded to before, and that may result in low patient satisfaction and lack of patient willingness to ask questions or to even answer questions, follow the prescribed treatment plans, or share information vital to making sure that the plans that are being made, that are being negotiated, are accurate. So, all of that is just strictly communication, and then we add that layer on about communicating with individuals with limited English proficiency. And we see that on slide 19, over 1.8 million individuals are duly eligible for Medicare and Medicaid speak a language other than English at home or do not speak English fluently. And LEP individuals are defined based on a census question: how well do you speak English? And it's very well, not well, or not at all. And if you answer anything less than very well, you're considered limited English proficient. As we've noted, individuals with limited English proficiency face a greater risk for poor communication during healthcare encounters, and it's associated with lower quality of care. Identifying and meeting the needs of individuals' language preferences is vital for effective communication and high-quality patient experience. And so, and when we're talking about language preferences, and I'm sure my colleagues are going to hit on this as well, there can be language preferences for both spoken and written. So that's another nuance that we should be cognizant of. In addition to what I'm sure are going to be great presentations from my colleagues, I just wanted to share two quick resources that we have at the CMS Office of Minority Health. The first being, this is some of many, but when we talk about identifying language preferences, data collection standards are out there. And so what we've done is created this compendium of resources for the standardized collection of demographic and language data. It highlights best practices and guidelines for healthcare organizations in implementing standardized data collection. It includes links to training tools, webinars, probably such as this one, and Sentinel articles and books that provide in-depth discussion and issues, challenges, recommendations, and best practices in standardized data collection. And then another resource which I help to lead is the development of a guide to developing a language access plan. Now, language access plans are not required, but they're just a good idea to have, because undoubtedly your plan or your clinic or your organization is going to encounter individuals with limited English proficiency. And having a plan in place allows you to be proactive rather than reactive in providing the best possible care to these individuals. So rather than saying thou shalt have a language access plan, we came up with this what we hope is a really user-friendly guide to developing a language access plan, and it walks organizations through some of the basic sections or common sections of a language access plan: the needs assessment, language services, so oral interpretation versus written translation, providing notices about the availability of these services, training. It's so important that everybody in your organization knows that you provide language services and how to access them and how to use them effectively, and then always making sure that you're evaluating the services that you're providing, not only to make sure that they are high quality, but that they are meeting your patient and beneficiary stakeholder needs. Making sure that the language is both linguistically but as well as culturally appropriate. So that's just a real quick overview of things. We will get down to the website where the 2 resources I just mentioned and many, many more is located on go.cms.gov/OMH. And please feel free to check that out. There's a wealth of resources there. But with that, I will end my part of the presentation and turn it over to Albert to talk about CalOptima. Thank you.
Thank you, Darcy, and thank you everyone for joining today's webinar. We hope that the information provided today will be beneficial for your organization. Today, I will be covering CalOptima's process for identifying member language preferences. So next slide, please. So just a brief bio on CalOptima. We are a county organized health plan. We are one of 6 county organized health plans in the state of California. We were established in 1993. We are the largest health insurer and the only Medicare and Medicaid plan in Orange County. Our membership is over 750,000 members, which is comprised of dual eligible beneficiaries, children, adults, seniors, and people with disabilities. We also offer a dual eligible special needs plan, or DSNP. Our membership is very diverse. Our members speak over 50 languages. Next slide, please. So in Orange County, we have 6 threshold languages. We have Spanish, Vietnamese, Farsi, Korean, Chinese, and Arabic. When a threshold language is reached, what it means is that we are required to provide written material in that language. Now the state sets the guidance on when a threshold language needs to be implemented. The threshold languages are required when a non-English language reaches 3,000 members, or those that meet the concentration standards of 1,000 members in 1 zip code, or 1,500 members in 2 continuous zip codes. So the reason why we focus on identifying and meeting language preferences is to ensure that our members receive member materials and notifications in their threshold languages and are greeted in their native language when they request assistance. It also allows us to monitor and determine how close we are to reaching a new threshold language so we can prepare and plan for implementation. Next slide, please. So we use several methods to identify a member's primary language and language preference. One is through the state eligibility data file that we receive, through the enrollment process when a member enrolls into our MMP, our Medicare Medicaid plan, or our DSNP plan, during the health risk assessment or the HRA process, and during daily customer service interactions. Okay, next slide. So CalOptima is the only Medicaid provider in Orange County, so all beneficiaries who reside in Orange County are automatically enrolled upon qualifying for Medicaid. So we initially learn of the member's language preference through the state Medicaid eligibility file. The file contains enrollment information, eligibility information, which includes the language preference data. Now at times, the data in the eligibility file is incomplete or inaccurate, so we do use other methods to identify language preference directly from our members. Now, next slide, please. So as I mentioned before, we offer a Medicare Medicaid plan and a DSNP plan. So members that are already enrolled in our Medicaid plan and meet the eligibility criteria for these plans can elect to enroll. So during the enrollment process, the sales agent confirms the member's spoken and written language preference. The agent records that information in the enrollment application. That application, when it's sent to our enrollment department, the language information is recorded in our eligibility system. The next slide, please. So upon enrolling in CalOptima's MMP or DSNP plan, all members are assigned a personal care coordinator, or a PCC. A PCC is a member's main point of person who helps with all aspects of their healthcare needs. And we work closely in customer service. We work closely with them to coordinate our efforts to help the members. This includes assisting the members with completing the HRA. So when possible, for threshold languages, the member is matched to a PCC who speaks their language. The HRAs are mailed to all new members when they enroll, and annually in the language preference on record for our threshold languages. The PCC conducts outreach to members at least 3 attempts to assist the member with completing the HRA using an interpreter when necessary. Any members that do not speak a threshold language receive a HRA in English, which the PCC, along with an interpreter, can assist in completing over the phone. So the PCC will confirm and update the member's language preference during this process so it can be updated in our system. Next slide, please. So our customer service call center staff frequently interact with members through routine incoming calls or during outreach calls. And because we are a local plan, we receive office visits from our members daily. Some members do, especially our LEP members, they prefer to come in person to request assistance rather than calling over the phone. When the member calls our call center, the calls are routed to a bilingual customer service rep based on the threshold language prompt the member selects, and we have prompts for every threshold language that we offer. And of course, for non-threshold languages, we use the language line to assist. So during their interaction, the customer service rep follows our established process for checking the language on record in our eligibility system and the language that is being spoken during the call. So if the language on record and the language being spoken during the call matches our eligibility system, then no action is taken because we know that the information is accurate. If the language on record and the language being spoken during the call does not match our eligibility system, the customer service rep asks for the preferred language and whether they would like for us to update our system. If there is a language preference change or update request, that information is sent to our enrollment department to process and update our system. Now, there are instances where a member wants the written material sent in English even though they speak a threshold language because their family members manage their health care. So we also take that into account and are able to enter the preferred spoken and written language in our system. But for the most part, the members that fall into our threshold languages want written information in the language they speak. And sometimes they ask for both. They ask us to send to keep the English language indicator in our system, so all the information goes out in English, but they do call and request the information in their threshold language, and that's upon request. Next slide, please. Okay, so as the language preferences are updated in our system, the information is also shared with the providers. So we share them in two ways. So our capitated providers, capitated contractor providers receive daily and eligibility monthly files, which contains this information. Non-capitated or non-contracted providers can access the information through CalOptima's provider portal. Any updates received by the customer service call center and other means will be added to the data file and the provider portal once our core eligibility system has been updated. So any further written correspondence and member materials will be sent in the threshold language. Next slide, please. So we hire multilingual staff to support our 6 threshold languages. Bilingual and multilingual staff are hired in several departments. Of course, customer service, culture and linguistics, grievance and appeals, community relations, case management, and behavioral health. And we believe that by hiring bilingual, multilingual staff rather than just hiring telephonic interpreters helps members feel more connected to our plan. Members tend to call more often when they have issues because they know they will be connected to, a familiar voice, someone they know, rather than having an interpreter, a different interpreter every time they call. Next slide, please. Okay. So our customer service staff goes through 5 weeks of training during onboarding. Additional training is provided as needed during monthly staff meetings and in one-on-one situations. The trainer addresses cultural competency and a step-by-step process, which I went over in slide 28, on identifying language preference. Now, part of the training is to include recordings of calls that were handled by existing staff. So the new staff that's coming on board can get an idea what to expect when they begin taking calls. The customer service trainers stress the importance of capturing the member's language preference as part of our overall customer service high-valued person-centered care that we provide. The trainer also reports to the supervisor and managers twice a week or more often on the status of each trainee and brings up any concerns that were observed, because we found that we can get a good indication of how a representative, a new coming on board, is going to perform based on the training and how they're handling the training, how they're absorbing the information, and so we get a good sense of what kind of rep that's going to be out on the floor. So customer service supervisors also conduct daily call audits throughout the month to ensure the call was handled based on our established processes. The audit form contains a section that scores the customer service rep on how well and accurately they identified the language preference of the member during the call. So even our call documentation templates have kind of a Q&A, questions and answers, to remind the staff as they're going through the call what are the standard questions to ask, like the PHI, and did the member request an interpreter? Did the member's language match our system? Yes and no, and if no, the actions they took. So every time the rep takes a call and opens up a documentation template, that information is always there, so they won't forget to ask or to go through that process with the members. Next slide, please. So language preference data is used to determine how CalOptima staff serves members through written material and interpretation. So for written materials, the information is used to identify members that would benefit from materials in threshold languages other than English, as I mentioned before. Some members want that information in English, but also request that information in their language, so they can be able to read and also have their family members who are, in most cases, mainly speaking English-speaking family members, handle their affairs. Materials are translated in all threshold languages through a three-step process, which is the document is translated by a translator. Then it goes to a second translator for review, which is now called a reviewer, and any edits or corrections are identified and then sent back to the original translator for final review and completion of the document. So this process kind of keeps a balance and check to make sure that the document is accurately translated. In addition to internal interpreters, we contract with vendors to provide face-to-face interpreting, video interpreting, and telephonic interpreting for threshold and non-threshold languages. This ensures that we always have adequate interpreters available for our members. And the video interpreting, it is helpful because when members come into our office, we have members that speak American Sign Language. So with that, we can get a video interpreter on the line where they can see the person using American Sign Language to communicate, and then we are able to communicate with the member in that manner. Next slide, please. Okay, so telephonic interpretation is always available to members. Face-to-face interpretation for medical appointments is also available, and we can provide this service as long as the member requests in advance. Usually 2 weeks. We ask members to call us 2 weeks in advance. If the member does not provide advance notice, we will make every effort to schedule the face-to-face interpreter. If that cannot be done, we'll arrange a telephonic interpreter so the member will still be able to communicate with the provider during the office visit. So the first step the member takes to request a face-to-face interpreter is to contact customer service. Customer service will take the request. The request is then forwarded to our cultural and linguistics department. The cultural and linguistics department would then contact the provider to confirm the date and time of the appointment, just to make sure that the information that the member provided during the phone call was correct. Because we found that when we didn't have that in place, we scheduled the interpreter, and we found that some appointments were on the wrong date or the wrong hour because the member got confused on what the information the doctor gave him or the appointment time. So we put that in place just to ensure that we have the right date and time of the appointment. After that is done, the CNL rep contacts our vendor to arrange the face interpreter. Once the interpreter is booked, the representative contacts the member to provide the update. And we also have contracted health networks or medical groups that that manage our members as well, and they have this same process. And we receive. They're required to submit quarterly reports to CalOptima that indicate the number of telephonic and face-to-face interpreters they provided, and this is on a quarterly basis. So CalOptima's motto is better together. Our mission is to provide members with access to quality healthcare service delivered at a cost-effective and compassionate manner, and we think it reflects what we do with our LEP members because it ensures that they have access to the healthcare without encountering language barriers. So I'd like to thank you for your time today, and I'll turn it over to Marta.
Great, thank you so much, Albert. Martha, we can pass the presentation.
Oh, I'm sorry, I was mute, so sorry. Good morning and good afternoon. It is a pleasure to present at this webinar regarding language preferences through partnering with community-based organizations. I represent the community-based organization. If we can go to the next slide. Typical community-based organizations, and I just wanted to say that clearly because often area agencies on aging are considered community-based organizations as well. Obviously, they are in part. CLESE, however, doesn't have any dedicated funding from any particular federal or state resources. That's why we are sort of, getting resources and taking care of our mission and needs, simply writing grants and to various institutions such as federal government and state government and private foundations. CLESE was formed in the late 90s as a group of immigrant and refugee community leaders who were asked to assist the City of Chicago Department on Aging at that time to conduct an extensive ethnic elderly assessment in the city and surrounding counties because the city saw culturally different groups, minority seniors coming or being present in the area, however, not being recipients of services they required. And findings from that assessment show that lack of language proficiency and cultural barriers obviously prevented those limited English-speaking older adults from getting services and programs they needed. At that time, those leaders who were assisting in conducting that research project have decided to form a permanent coalition because they work together very frequently. They were conducting practically those interviews with older adults, and they were moving that research project forward. And they discovered that they have much more in common than differences. So since then, CLESE is in operation for a little bit over 30 years in the state of Illinois. On the next slide, you can see that we are composed of about 55 ethnically diverse, community-based social service organizations. Typical social service organizations, again, who are getting grants and programs based on applying for those grants. We represent more than 50 ethno-linguistic groups and speak over 100 languages. Illinois is a very welcoming state. It's in the group of 10 states which have the largest number of refugee resettlement process going on. As a group, as a coalition, our member organizations serve over 200,000 clients every year, and majority of those clients are older adults, 60 years and older. And we have sort of our role as a coalition, as an advocacy group, is sort of twofold. We work with providers who conduct home and community-based services as well as other services to their respective communities. But we also work with limited English-speaking seniors directly through this providers network. We do conduct our mission by providing leadership, education, and advocacy. We do inform both providers and seniors about various policy changes, system changes, new transitions in the system, such as transition to managed care. We also provide some direct services, recently including interpretation services. In the next slide, you can see that as a group, pretty large group, which is comprised of various immigrants and refugee groups, we sort of have that first-hand knowledge of what that means to be an immigrant, what that means not to speak the language well, how to manage, how to understand the reality around me, how to navigate care. So this is a very unique experience, which we eagerly wanted to share with plans in our state when managed care transition occurred, to help them better understand that experience. And that partnership, that partnering process with plans is definitely mutually beneficial and truly profoundly impacts the lives of members of those plans. As a result of our partnership with managed care plans, we were able to establish a formalized language access center. That's the direct service unit, which basically was created as a result of the process of transition to managed care in our state. In the next slide, you can see obvious facts such as that the language and cultural differences definitely create barriers, and both of my predecessors so eloquently spoke about it as well. Especially that slide where we talk about, I believe Darcy was mentioning that, those 6 domains of healthcare quality. One of them is patient-centered approach, which is sort of a dominant idea in care, in the healthcare today. You know, there's no patient-centered approach without without understanding of the process by the patient. And being able to communicate back with the healthcare provider. So those barriers in communication are addressed by the services we provide. We've noticed when the managed care transition started occurring in our state that it was a very overwhelming process for many people, especially limited English-speaking communities, and among them older adults. They truly couldn't understand what is happening around them, how to read and understand various correspondence coming from the state regarding enrollment process. The letters that were coming were not necessarily properly addressed, and they were ending up in the garbage can, briefly speaking. People were not aware of following the deadlines, that they didn't observe those deadlines. They didn't understand why they should follow up on those deadlines, as well as the opting out, opting in process to various plans. That was definitely something, until this day, older adults have difficulty navigating, and how, let's say, opting out of certain plans will affect the rest of their services. Communicating effectively with care coordinators became a humongous problem because members couldn't do this openly, couldn't say anything back, couldn't talk freely about their needs and wants, as well as weren't able to navigate their care. So on the next slide, you can see that the transition to managed care, in our state at least, it was something which came very quickly, and nobody was prepared how to navigate that change. It came as a result of ACA as well as local SMART Act enacted by our General Assembly. It was called Safe Medicaid and Resources Together Act. I think it was enacted in beginning of 2011, which was addressing Medicaid problems in our state, and mandated that 50% of beneficiaries should be enrolled in the managed care system by January 2015. So that was a lot of work, which we realized that if we will not get involved and start working extensively with various stakeholders, it will be big loss for our clients at that time. That transition to managed care created confusion, obviously, and for both providers and clients, especially older adults. We didn't have any prior examples of how to proceed during times like that in terms of that transition. So plans also realize, at least some of them, I should say most of them, that it is a challenge for them as well if there are needs for addressing the language preferences among members and how that should be done. We realize that that process of addressing language preferences has to start at the beginning of the whole process, such as the enrollment. We basically took an active role and reached out to the leadership of various medical plans which were present, which were coming to Illinois at that time. And we started talking about the needs and language preferences among limited English proficiency populations. In the next slide, you can see that basically we were doing this various ways, I should say. We were approaching plans. We were approaching our providers in the state, mostly minority providers, but also regular providers, mainstream providers were joining those meetings. We started organizing bi-monthly meetings with plans, various plans, based on their availability as well, and providers of home and community-based services, and generally providers of other services as well. Federally qualified health clinics, for example. We had many of those always present during our meetings as well. So we were meeting together. We were addressing the issues of language and cultural barriers among limited English-speaking populations in our state. We were then in detail meeting with providers, sort of on separate basis, and talking about transition to managed care, particular processes such as contracting, billing, clients transfer. All those aspects were topics for those meetings. We were doing this via webinars or one-on-one consultations. In the next slide, you can see we also were holding, at least quarterly, some cultural competency trainings to plans. And it was different than the cultural competency trainings which plans had ready for us. We were talking about our knowledge, our immigrant experience and our knowledge of clients whom we know by name and whom we serve for many years. And we were bringing that experience to care coordination staff of plans, and they really appreciated that. We were able to help and assist plans in identifying members and identifying languages spoken as well. Because we know our clients for so many years, and that was a very useful, CLESE became a very useful resource for plans. We also work with an enrollment broker in our state, realizing that there were certain state requirements when people were calling the first time or second time trying to enroll to some plan. They were expected to say in English what language they speak. For some languages, we realize it's almost impossible. So for some Asian dialects, to say in English the name of that dialect, it was basically very, very difficult for that person to do. So we were working with that enrollment broker, basically making them realize those type of barriers in the caller and how to address them and how to better understand that type of challenge. So we had a number of meetings with that enrollment broker. At that time, it was the beginning of the transition to managed care process. We also started Department on Aging, local Department on Aging, Illinois, realized the need for addressing the benefits assistance in more, sort of broader way and embracing the diversity of Illinois and they were contracting with CLESE to provide senior health insurance program education and counseling to members. And at that time, it was, I think, 2013, we started working with the department on SHIP program, addressing those type of needs. It became a very successful program because there's a lot of need among minority populations regarding those type of issues, benefits access in their own languages. The next slide shows that we also work not only with providers and plans, but we also address the population itself. Through Providers Network that we were able to reach members, future members of plans, and with educational pamphlets, information, discussions about transition to managed care. We try to sort of, at least make some first steps in that process. Plans obviously came well equipped with their own tools in terms of addressing language preferences, mostly via phone, and potentially maybe interpreter services through language line or other sources. But we realized that people locally, if they're on the local level, they sometimes interpreters who are coming and sort of to the phone and try to talk to our members might lack some specific knowledge regarding the managed care transition in that particular state at any given time, and sometimes those services were not very accurate. We were just getting that feedback from clients, so that's something we realized simply by talking to clients. We were educating. We were trying to reach clients through various venues such as educational sessions, media campaigns. We have a lot of ethnic media venues in Illinois, in the Chicago area, northern Illinois. So that all of those were very useful. And at the same time, we realized that we became a good resource for plans, and we established that formalized language access center. Within that capacity, we provide not only in-person and also telephonic interpretation, but priority is given to in-person contact. But we also assist care coordinators of plans in scheduling those visits, following up on those visits, scheduling and being part of family meeting if necessary and if requested by care coordination. We also we kind of follow the member wherever the member is. Sometimes the care coordination might be asking us to not only assist at home during the home visits, during needs assessment process, but also in the hospital setting, doctor's visit, resolving sort of small issues, but which have to be resolved on the spot, sort of speaking. So we are always available to do that. So this is a comprehensive in-person. Next slide is showing that comprehensive in-person language access assistance to health plans. Our state helps with initially identifying the languages spoken by members, but this is not always accurate. Plans often tell us that the lists or information that is given by the state is not always accurate in terms of what type of language any member speaks. So currently we have about 5 contracts with plans, various plans. And we are often asked to investigate, quote unquote, and identify that language preference. When we're scheduling the visit, when we're establishing that initial report with the client. We have about 10 to 25, as I say, 10 basically, like largely spoken languages in the state of Illinois, including Spanish, Polish, Cantonese, Mandarin, various Asian, South Asian languages and dialects, Middle Eastern languages and dialects, East African languages and dialects. But it also grows specifically when particular refugee group is present. And we're dealing with rare languages, as we say, and we are definitely able to identify the interpreter of such language as well. In terms of training, We are focusing on various aspects of that home visit and care coordination. We are ourselves as a CLESE staff running that type of services. We've been trained by plans on various aspects of care coordination, on the assessment tools, what that entails, what to expect, and we are able to take that knowledge and convey that knowledge to our interpreters who are already certified, most of them medical interpreters with a good experience, but we also adding to that experience additionally. And there are various aspects of the home visit or scheduling that visit or visit in the hospital settings, nursing home, where they learn new aspects of that type of interaction and accuracy in translating that type of content. Often our interpreters serve as cultural brokers. And they are conveying not only the language and the message, which is in any given moment crucial, but they also are able to convey the cultural ramification of such message. They are able to help care coordinator understand why the member behaves certain way, why certain comments are coming out of members, why they say, well, we never talk about death and dying in our culture. This is something which we would never address. Member, of course, talks about it certain way, and that interpreter is able to convey that message to the care coordinator, which is crucial. In that current slide, you can see that presence of in-person interpreter at client environment, home, hospital bed. It's really bring them comfort and good understanding of what's going on in that interaction and at any given moment. It empowers the member to truly address their need and encourages the member as well to reveal any significant information, which might be very important at any given moment of that process of caring for that person. CLESE contributes to building that strong relationship between members, plans, and interpreters. And often care coordinators are asking for a particular interpreter to visit members. They're feeling very comfortable. There's a rapport, there's a relationship already established between care coordinator and interpreter, and they go together. They are able to address members. They work together well. And they see this as an effective process, and when care coordinator is satisfied, they're letting us know, I would like to work with that particular person because I had a great experience for a long time. And we always are able to set it up that way. We know that when the care coordinator is at member's home and they leave that business card with them, it is very natural for care coordinator to do that, obviously. Please call me if you have any questions. And we can translate that. But what that really means for the member usually will never call on his or her own. They will not be able to address that process and going through all those steps of connecting with that care coordinator. So we are able to sort of step in and say, this is what you could do. This is, and care coordinator sometimes say, we have additional telephonic services, you can use them. Sometimes, however, we have a situation when the member is calling us, CLESE, and is asking, can you please help me call that care coordinator because I have a question? And we, of course, doing that. So in that area, when I was mentioning that cultural broker function, sometimes we really build that strong relationship which helps member basically be more proactive. And instead of going through various hoops when it comes to calling an authority figure, which care coordinator is exactly who that person is, for that particular client member, they call CLESE because they feel like they can speak openly and freely about their need. On the next slide, we can see an example of such visit. For example, we had that situation fairly recently when we were visiting Ms. Torres. Her name was changed, obviously, for the purpose of this presentation. And she was about 75 years old. She was an immigrant from Ecuador. And currently in Illinois, we have that program called Health Choice Illinois, where the state was choosing a couple of plans, and members and people, clients, have to enroll to those plans. And again, the whole process is a little bit confusing for clients, for older adults who don't speak English, because they don't react necessarily to the letters which have been sent out. So they are being auto-assigned to new plan without necessarily their knowledge of that process. And because of that barrier and lack of knowledge how to manage that system, Ms. Torres was assigned to some plan, and there was a care coordinator from that new plan calling her, trying to, through Language Line or some other vendors, trying to set up that home visit. And she was refusing. She was very upset. She said, why they are calling me? I already had some visit recently in my home. And what we've discovered in the next slide, obviously, that visit indeed took place, but it was with different plan and different care coordinator. So she was right. However, that was a different medical plan at that time. So the new plan was asking CLESE to reach out to Ms. Torres and establish that relationship and ask her if she would be able to accept the home visit. And after some conversation and explaining plenty of detail regarding that process of auto-assignment or why she is in a new plan, etc., she was able to accept that visit. In fact, that interpreter who called her worked previously with the previous plan and previous care coordinator with the same member, Ms. Torres. So she recognized that person. She already had some established relationship, and she was able to accept that visit from the new plan. And that's because of the trust established between CLESE, between care coordinator and the member, that she felt very much okay accepting that visit and being active part of it. Later on, the care coordinator told us that she was able to gather all necessary information regarding health risk assessment and other details regarding that particular member. So that was a very successful visit ultimately. The last slide is talking about potential strategies for plans to partner with local community-based organizations, because local CBOs are a great resource for plans in any given state. So based on our experience, we strongly recommend that when you're searching for a ophthalmologist that speaks Cantonese, in some states Cantonese might be a rare language. Many of them, in many states, Cantonese is not such a rare language when it comes to minority languages. But if you have such need, you can definitely utilize local resources. Those community-based organizations have that type of knowledge. We also encourage plans to recognize an ongoing relationship with community-based organizations. And they're a good resource and good information source on languages spoken in your state and among your members, as well as various cultural information they might basically present to you regarding minority populations. And also, based on our experience, CLESE's experience, collaboration with minority leaders in your area might be very useful in helping you understand the cultural language differences and how they affect health outcomes among your members. CLESE is working, developing more services and expanding its services outside of our state and going to various states. So it might be a good opportunity for us potentially collaborate together in the future. Thank you so much.
Thank you so much. Thank you, Darcy, Albert, and Marta, for all of your presentations. This has been incredibly informative. Thank you so much for joining us. And with that, we now have a few minutes for questions from the audience. At this time, if you have any questions for our speakers, please submit them using the Q&A feature on the lower left of the presentation. Type your comment at the bottom of the Q&A box and press Submit to send it. So I'll get started on some questions for our speakers. Albert, I'll start with a question for you. You mentioned that you have customer service staff speaking your threshold languages. Do you have any recommendations for how to recruit multilingual customer service staff that speak threshold languages?
Yeah, I think My recommendation is, of course, starting from the very beginning, from reviewing the resume, making sure that they have the capability of speaking the language and conduct testing, because we do run into a lot of resumes that say they speak a certain language, and when we get them in an interview, they don't. So that's one thing. The other, make sure that the candidate has customer service experience to some level of degree, because when they get into the call center and we're dealing with members' health, we prefer, at least in my experience, that somebody that already has that experience, a background in customer service, not necessarily healthcare, but dealing with members, interacting with members. And the other aspect, which I think is equally important, is identifying candidates that have natural empathy, a positive attitude, and enjoy interacting with seniors. Because for those people on the line that work in call centers, this is not an easy job in dealing with seniors. They're challenging at times. They're confused about what to do, and we need people with a lot of patience and just a positive attitude, and they can connect with those members in their language. So that's the recommendations that I would give.
Great, thank you. To follow up, you mentioned that someone might have on their resume that they speak a certain language. We had a question from Kathleen in Pennsylvania. Do you use a certain language test for your bilingual and multilingual staff to assess for competency?
Yes, we do have a test that we provide verbally through. We do contract with a vendor that conducts a phone interview as far as just having a conversational, for example, if it's Spanish, conversational Spanish, asking questions, just not necessarily about healthcare, but just make sure they can carry in conversation, they understand the language in detail.
Great, thank you. So this question goes actually really to Martha or Albert in both your experiences. So whoever wants to start first. So the question comes from Maya in California. How do you ensure staff are equipped to translate medical terminology, understanding a language, and then being proficient in understanding medical terminology in order to translate are slightly different things?
I can start. As part of our training, we do have medical terminology kind of a guide that we go through, and it gives the medical terminology in different languages. As new if we have new terms that we don't have, we submit them to our Cultural and Linguistics department, and they can translate and then update the guide as new terms come up. But we usually start off with that, and usually the training is ongoing. We do have initially when reps are hired, an ongoing basis, we do remind the staff, and what we do is we identify during the audit process, listening to calls, the supervisor identify if the reps are using inappropriate terms or terminology for certain medical words or medical terms. So we identify that as a training opportunity, and then we revisit the list.
If I may also follow up on what Albert is saying, CLESE is following the standards of National Council on Interpreting in Healthcare, and we work with that entity closely. Not only we follow their standards in terms of proper interpretation accuracy, but also ethics and standards of conduct during that interaction with a member and plan. We also, when we were trained as staff of CLESE by plans regarding the content of needs assessment tools, we asked them for the list of vocabulary, for glossary, if you will, of certain terms. And we were sort of brainstorming together regarding what are most appropriate terms being used. And we then take it with us and train our interpreters on that as well.
Thank you, Martha. So for both of you as well, what kind of steps have you taken at CalOptima or CLESE to address language speaker shortages? Have you encountered any situations where the pool of qualified speakers is shallow, and what were you able to do about it?
if I may start, just briefly, we definitely feel that in certain languages, especially rare languages, if those requests are coming, we might have a shortage of folks who are professional interpreters. We are, I should say, we are, in a sense, a little lucky because we are comprised of various immigrant and refugee groups in our state and outside as well. People start to recognize CLESE. So through those providers networks, we are able to identify various individuals. In fact, providers are helping us in recruiting and screening appropriate people who can become interpreters. So in that sense, we have sort of this ability to reach out to various people through our providers network. But, one situation I can just briefly tell you that was very rare language and a certain dialect of South Sudanese language. And we were asking the plan if they will be okay with recruiting somebody outside of our state and if it will be okay to have that interpretation done by the phone, not in face-to-face. They agreed, and we were able to identify that type of interpreter through the network of refugee resettlement agencies, for example. CLESE works closely with those type of services as well in the country, and that person was recruited in Colorado. So we were able to link the member, the care coordinator, via phone with that rare language speaker.
And this is Albert. I agree with Marta. We live in an area where our community is very diverse, so we have a multitude of languages. Our face-to-face interpreters, we have vendors that are able to provide language for not only our threshold languages but other languages as well. We haven't really, felt that we have a shortage because we also have our vendors, like Marta said, if we don't have a face-to-face interpreter, we can always rely on the telephonic interpreters. And our vendors that we contract, they have available over 200 languages that they can provide.
Great, thank you both so much. Martha, you talked a little bit about the importance of identifying partnerships with community-based organizations for plans and the value that community-based organizations can bring. Can you say a little bit more about how plans might go about identifying those partnerships?
That's a great question. I would recommend to focus on 2 state agencies per state. One is one which manages Medicaid in our state. It's a Healthcare and Family Services, Department of Healthcare and Family Services. And the second is Illinois Department on Aging. These are just examples. 2 entities, and in various states, many states, we have a variety of options. I think in some states, Medicaid is might be different name of particular department, but I would maybe start there. It's a very good question because I've learned myself that certain states don't have providers networks of home and community-based services. Services are being provided by area agencies on aging, and those entities are employing workers directly. So those type of systems are absolutely very different than in our state, for example. But area agencies on aging are a good resource to learn about diverse resources in any particular county or larger area, larger region. Per state, in our state we have 13 of them, and they should be a good resource of information. How to start? Where are those names? Where are those particular CBOs who might be of help to plans or might be useful as resource to plans? So that's how I would look at that, probably.
Thank you so much, Martha. Albert, can you talk a little bit about what happens when a member who speaks a non-threshold language, if you've given the example of French as a non-threshold language, if they receive correspondence from CalOptima, you've mentioned that they would get it in English. Is there a process for helping them understand that material?
Yes, we do have a process. The majority of our member notices and the material that we send out have have a what's called a material ID number at the bottom left of each of our correspondence. So if a member calls and they receive a correspondence, our process is we would get the interpreter on the line and ask the member to provide that ID number on the correspondence. Our CSRs, customer service reps, they have access to these materials, so they are able to identify the type of correspondence, and through the interpreter they can read the letter to the member or the correspondence. And this applies to all members also, because we get English-speaking members, they get letters they're confused, and they're saying I received a letter and they can't read it, so we ask them for that information. So that's our approach to identifying letters and providing that information to non-threshold language members.
Great, thank you. Albert, also for you, in terms of the interpretation actually being provided, how do you determine the quality of the translation? In terms of both the quality, in terms of the accuracy of the information that's being translated, as well as the quantity, making sure that all the information is translated. Those can be particular challenges, and this question comes from Min in California.
Well, the quality of like I mentioned in my presentation, we have a 3-step process when it comes to translating documents and materials. So we have both internal translators and external vendors. So we, depending on the volume of the request, we either vend stuff out to, correspondence to our vendors, and they translate them. They go through this 3-step process as well. So they translate them, they go to a reviewer, the reviewer reviews it for accuracy and makes any edits, and then sends back to the original translator to make the final, to finalize the document. So that's our process. We found that it's fairly accurate when we do that. It ensures that that the translation is translated accurately.
And how about ensuring the quality of translation in person? Is there anything you do to make sure that your interpreters are able to translate accurately?
Interpretation. Okay. So interpretation. Yeah, I mean we do, like I mentioned, we audit the calls. All the call audits are part of the evaluation that the representative interpreted the call accurately. So that's part of our process.
Great, thank you so much. And another question for you. For your PCCs, your personal care coordinators, I'm sorry if I'm misremembering the acronym. This question comes from Richard in Florida. Do you have PCCs for all of your threshold languages?
Yes, we have PCCs for all the threshold languages. The majority of the major threshold languages that we have here, we have 6 threshold languages, but the main ones with the higher populations are Spanish, Vietnamese, and I believe Farsi. Korean, Chinese, and Arabic are part of the threshold languages, but they tend to be lower than the Spanish and Vietnamese. So we do have personal care coordinators, and we try to match them with the member that speaks that language.
Okay, thank you. So we have a couple of questions asking about if you have any staff that might have interest in learning a new language to be able to speak one of those languages, whether it's a threshold language or not. Is there anything that you do to support staff or help staff get training in order to learn proficiency in another language?
Is that question for me?
I think yes, but Martha, if you have anything to add, feel free to jump in as well.
If I may just start, Albert, if that's okay with you. I think, humbly to myself, that the whole sense of interpreting for another person, you sort of have to be native speaker of that language in order to, at least in sort of our perception, in order to be accurate and truly be that cultural broker, understand that culture, and sort of coming from that culture. But we might have people, for example, our staff, regular staff in CLESE office each person speaks at least one or additional language. And we do utilize our staff if it comes to certain particular question or very short clarification regarding a question from care coordinator. So for sort of like, I would say, less like little sort of things, for the lack of a better word, like that, for certain clarifications or other smaller quality things, we might, if necessary, if we don't have at any given moment a particular person available in any given second, our staff might step in and do that. But we sort of always believe that the interaction between care coordinator and the member should be definitely facilitated by a native speaker of the language, a fully qualified, professional, certified person.
Thank you so much, Martha. So,
You're welcome.
Albert, I would love if you have any input or if you have any experience working to train any of your staff members in additional languages if they have interest.
No, we don't have that process here.
Okay, great. Thank you so much. So, Albert, a question for you about, you mentioned a little bit about the importance of having bilingual customer service representatives and how that makes members feel comfortable and more likely to either call in or come into the office. Can you say a little bit about why that's important, how that helps create a great experience for LEP members?
Yeah, through my experience, I think the members develop a greater connection and a higher level of trust with our plan. We have members that develop an attachment to certain customer service reps because they speak their language, and they usually have a higher comfort level that their issues will be addressed and resolved. So when they call in, they request, when they call in or come in, they request for that specific rep. So we do our best to accommodate whenever possible. And also we have members that also develop a relationship with the face-to-face interpreters when they go to the doctor's office. Usually some members want the same interpreter every time they have an appointment, and sometimes if the interpreter is not available, they want to reschedule their appointment so the interpreter could go. So we evaluate that and try to meet the members' needs whenever possible. And also I want to add one of Darcy's slides about effective communication. I think it does create a better experience because I can attest to her presentation that members are more satisfied with the plan, and they do tend to share more detailed information about their health, what they're going through. With the customer service reps and also the face-to-face interpreters. So I feel that's a benefit for us because we can sometimes identify members' conditions, faster rather than having that language barrier.
I would absolutely agree with you.
Wonderful. Thank you both so much. I think those are both very important point. At this time, we're wrapping up our Q&A period, but if you have any additional questions or comments, please email ric@lewin.com. For more information, you can find each of our speakers' contact information listed on this slide. The slides for today's presentation, a recording, and a transcript will be available on the Resources for Integrated Care website shortly. At this time, the post-test for this webinar is now open. Additional guidance about obtaining credits and accessing the links to the post-test can be found within the Continuing Education Credit Guide in the Resource Guide on the left-hand side of your screen, or at the Resources for Integrated Care website. Thank you so much for joining us today. Please complete our brief evaluation of our webinar so that we can continue to deliver high-quality presentations. If you have any questions for us, please email us at ric@lewin.com. Thanks again to all of our wonderful speakers. Have a wonderful afternoon, and thank you so much for your participation.
That does conclude your conference for today. Thank you for your participation and for using AT&T Executive Teleconference. You may now disconnect.